All right. Well, listen, let's get to it. And our guests are already joining us. We will be speaking to Dr. Richard Selimi, General Secretary of the Ghana Medical Association. But I want us to start with Dr. Anthony Insia Asare, who's Presidential Advisor on Health, because he does have another engagement coming up soon. So let's take advantage and hear from him before he has to leave us. Dr. Insia Asare, good morning and thank you for your time.
Thank you very much.
All right. Now, Doc, the problem is well known. We've understood it for quite some time, and the numbers keep increasing. We're learning from recent reports that 50% of the medical professionals that we're training in Ghana end up leaving. That's big. Half of them. What is the plan to stop this?
Yes, thank you very much, and good morning to your cherished listeners. Yes, brain drain is something which works of every thing.
Right.
Developing.
Doc, I think the line is not very clear. It might be your positioning. Is it possible to reposition yourself and let's see if that improves? Okay? It sounds better, Doc. Let's see if we can. Let's see how
I'm
we
at
get.
TV now, and network here is terrible.
I can imagine. It does sound better for the moment. So please go ahead.
Okay. Yeah. Okay. So good morning to your cherished listeners, and good morning to the panelists. Brain drain has been there with us, and it's for every developing country. Ghana is not an exception. We are in an economic situation, or we are in a world where there's a lot of competition. And you realize that people normally move to where first they can get better or conditions of service or better economic situation, better themselves. And if you zoom in into doctors, there are two things why doctors either migrate or stay. One is maybe for economic reasons, but one of the most important things for young doctors especially is for career development. So all what you have to do as a country, which we have done before, is to tackle these two and then mitigate the effect of brain drain. If you remember, somewhere in the late 90s, even apart from early in the 70s, Saudi Arabia needed a lot of doctors, professors to set up their medical schools. So for the first time, a lot of very well-trained lecturers and teachers and professors of the medical school in the country left for Saudi Arabia. Later, most of them came back. And secondly, during the late 90s, early 2000s, a lot of young doctors left. Even in the early 80s, a lot of young doctors, including our class, also left for Nigeria, because Nigeria economy was booming, even though there was no opportunity to do very structured postgraduate system there. Because there was only the West Africa College of Surgeons, West Africa College of Physicians, which was in the West Africa sub-region. Nigeria had a national college, which people were not going. They were not going to Nigeria, or people were not leaving for Nigeria before because of postgraduate training, but because they want to better their system. And most of them came back, and some left to the U.S. to also continue career development. Then late 90s, a lot of young doctors were also leaving because it took a very long time to be able to finish a postgraduate system in the West Africa College of Surgeons, West Africa College of Physicians. Because it was not well structured. The people were doing it for about 10 years when your colleagues or your mate in the US or the UK, about 5 years after graduation, can become a specialist in one of the disciplines. So what happened was that there were some mitigating factors which were put in place. First, there was the additional duty hours allowance to improve the salaries of health professionals, including doctors. And later on, in the early, I think around 2006, 2007, the management of the additional duty hours was become a very big cumbersome because the productivity was not matching the allowances which were being paid as additional duty hours. So the government decided to take health professionals out of the Ghana Universal Salary Structure, what we call GUS, and then consolidate allowances and salaries as a composite salary structure for health professionals. There was health service salary structure, HSS. There was HSS 1 for doctors and also the management staff of the Ministry of Health. And there was HSS 2 for the other health professionals, including nurses and pharmacists and the rest, which better the conditions of most of doctors and other health professionals in the country. So the salaries were out of the general universal salary structure. And we also then put in place the Ghana College of Physicians and Surgeons, which was established about 20 years ago, which was a structured training program for doctors where you finish your house job, you can enter the Ghana College of Physicians and Surgeons. These two factors mitigated and they reduced the number of people who were migrating. And that's why I say that if you want to tackle this issue, the most important thing is to make sure that you prevent the push factors and then improve the pull factors into the country. And that's exactly the then government from the late 90s to 2000s and 2008, 2009 did. And then we then went into at that time, I quite remember, Nigerians were also coming here to do their medical education. And I can tell you that most of the Nigerians who studied here remained here because the salary then was better compared to what they were receiving in their country. So nobody moves to a place where there's a lower salary or there's no postgraduate opportunities. And some of them also did the Ghana College and they are now specialists working still in this country. And then the SSS came. And remember, there was a hula baloo about all of that in 2009 when the police were paid first. So the health professionals, including doctors, they opted to join the single spine salary structure. And the single spine salary structure is from step 1 to step 25. So everybody is supposed to be in the spine. And then it became very difficult how to treat the extra additional duty allowance which has been consolidated in the health service salary structure into the single spine. And I think it was given as a factor of whatever basic salary that a person receives. That reduced people's pension contribution considerably. And then after some time, it was supposed to be a percentage. At first, I think some of them was about 2.5 times what the salary. And later on, it was grandfathered, and now it has lost its value. And then secondly, the foreign exchange also was also a factor at that time. You remember that around that time, before the Ghana cedis to US dollars was about 1.4 or 1 to 1. So if you convert that time the salaries into dollars, it was very reasonable. And that's why most of the Nigerians and most of other foreigners and Ghanaians were staying, and they were doing their postgraduate training also quickly. So if you get the two factors right, then at least some people will then be enticed to stay in the country, and that's exactly what happened. So we know the solutions, we know what to do. So recently, what we also realized that we have housemanship training. After that, people have to go and do, say, 1 year extra and all sorts of things before you are given study leave. The postgraduate system was being paid for by the students for the exams and training and all these things. But now, thanks be to God, and now nobody pays fees for postgraduates, especially doctors. So that is also removed. And we are now streamlining the postgraduate system from this academic year, I think from September this year, to make sure that all the cumbersome and all the other things which were in place for people to enter the Ghana Postgraduate College has been removed, so that you can go straight after your primaries to do your postgraduate system under your 1 year post 2 year housemanship training or not. And if you streamline all these things, I'm also thinking of adding more training sites so that I can take a lot of people. And then we decentralize with this system, at least the career progression is then taken care of. And then once the economy then booms up again of the CD dollar ratio, conversion factor is also contained, then whatever money you get here, at least it will be a bit comparable, like in the early 2000s. So this is, to me, the two important ways that we have to do to mitigate the brain that we are now all discussing. In addition to other factors like people should be paid for work done. Productivity is very, very important. And then we are now also thinking that anybody who is sent to any place, there will be a decent accommodation for the person to stay in. All these things we can do, especially the accommodation factor. Government cannot do it alone. We have to do it with the private sector. And I'm very happy to say, why I said, there are a lot of private sector people who are much more interested now to help us to put up accommodation for health workers, like we have done for the judges and the rest, so that we have a medical village wherever a hospital is, especially. I'm not going around monitoring Agenda 111 in Upper East, Upper West, the Northeast, part of Northeast region. Started on Monday. There are some areas, if you don't add more accommodation to the place, it will be very difficult for people to move there. So we have to entice them. Create medical villages around the country where there will be amenities and schools and everything for the health workers, where if the person is in a rural area, then we have a rural area incentives, like you have accommodation allowance added to it so that it can be used to pay for the private sector. These are some of the things we are putting in place and we are making sure that it happens. In addition to promotions, in addition to also giving extra incentives for those who are in the rural communities and hard to reach areas, and also underserved disciplines.
Right.
If you do all these things, what happened during the early 2000s and then the late 1994 are all put in place. 1990s are put in place. Then we can then make sure that we mitigate it happening. But I'll add quickly that we cannot, as a country, compete with those who are changing their rules now. Because at first, if you want to work in the US or you want to work in UK, even if you are a specialist, you have to go through another training or another set of examination. But now I understand that they've relaxed all those rules because they need people post-COVID. So we are competing with these giant economic countries who can pay, or whose salaries, if you look at it at their condition of service, is above what is in the developing countries or limited middle income economies like Ghana. So we have to put in place so that we can mitigate the brain drain. And to me, and this is the advice that we are giving, that we should have career progression where students we should have also established places of accommodation, and we are putting up new hospitals. So there will be a lot of new machines and new equipment which you will work off to have. If you are at a place where you have your CT scan, you have MRIs, you have ultrasounds, whatever you want to work off with, the equipment are there. Then at least that's your job satisfaction. In addition to also make sure that we also look at the conditions of service of these health professionals, doctors and other health professionals. To me, that is the way we have to go, and then we can mitigate and then reduce the number of people who are leaving the country.
Right. Okay. So to be clear, it sounds like everything you've outlined is a plan, something you are proposing should be done to solve the problem. It's not what we are currently doing. Does that mean that
something that we have started doing? It's something that, because that's the reason why I saw, for example, we are going around to make sure that we have a lot of hospitals in all the districts. We are making sure that these hospitals come with the right equipment. These hospitals have the right accommodation to also staff. The staff can also live in a decent accommodation. And then we then sit down with Ghana Medical Association and all the associations and then negotiate also their condition of service. And we see there's also underserved and deprived area allowance. Then we socialize that one and then we move on. So it's something which is ongoing. not that there's something that we have planned.
Nigeria has just signed a new policy to even start attracting those who have already left to come back to Nigeria, and those who trained abroad to come and use their skills in Nigeria. So they've set up things like incentive schemes to help them acclimatize into the Nigerian system, which includes accommodation and a lot of the things you've mentioned. But in addition to all that, they are also setting up bilateral agreements with some of these countries that need trained medical professionals from Nigeria. Now, in exchange for every one worker you get from Nigeria, you will train one worker to return to Nigeria and offer their medical services there. So this is a government-to-government agreement that has been made to help reverse the tide of brain drain. Is Ghana thinking of doing anything similar to that?
Yes, our front bearer will be launching the manifesto. I didn't want to take the word out of it. We have also plans like that. To tell you some bit of what we want to do, we in the country, for example, doctors, we have what we call the Ghana Physicians and Surgeons Foundation in the U.S., which we have been attending their meetings. We are working together with them. They are nurses, they are physiotherapists, pharmacists also in the U.S. and the U.K. Those are people who have gone out there. They are all willing to come back. So maybe I will just make a small decision, but I wanted to wait for our flag bearer to speak on Sunday. That's why I don't want to go into details. But these are some of the things that we are going to put in place. There will be a whole unit or agency which will be working together with our brothers and sisters in the diaspora. We need them for training. We need them to also help us to better our quality of services in this country. But a lot of them are specialists and super specialists. And if you want to have very top specialists in this country to be able to train our young ones who are coming from the medical school, we need to also attract them in.
Right.
And there are a lot of incentives that will be given to the diasporians to also come and help.
Right.
The government-to-government bilateral negotiations also, we even started talking. We started moving with them. But you see, we have what we call the World Health Assembly figures, where we have to be at a certain level before maybe we can actively send nurses out like the Philippines are doing. Luckily, we are training a lot of nurses, but you see, the nurses that these countries want are the specialized nurses, and that is how we are going to deal with them, to be able to train more perioperative nurses, train more specialists, maybe doctor specialists and all this. If you have more than enough, why can't you then arrange? And then every year, that is the numbers that you need. And then you are assisting us in the training of all these health professionals. And then we'll know the number that we can take them. Because anytime people move outside, not that they are of no use to us, they all want to come back. I was so impressed and so amazed that even those Ghanaians, the doctors who have Ghanaian heritage, that their mothers and fathers are Ghanaians or one of their parents are Ghanaians, are even more active than those who migrated from here.
Right.
And they are willing and eager to come back home and assist. They may not like to come and stay here forever, but as they do in India, as they do in other countries, to be working together with us in the health sector to make sure that they can then impact any knowledge that they have. Most of the things that they want to do it even for gratis. And those who want to come back and set up specialist hospitals and the training centers in Ghana, we are also enticing them and we are discussing it and let them come home. So maybe we took the decision maybe earlier than the Nigerians.
Oh, okay.
We have been dealing with them for the past few years.
Dr.
We
Nsiasare,
haven't announced it because we want to have it well established. I know that the GMA president have been to us to this annual conferences. Almost every time that we go there, the GMA has a representation there, and they know what we are doing. And the nurses, we have to take them there also to meet their nursing counterparts. And they started coming in. But with the countries who need our health professionals from this country, that is how we are going to engage them. We've already engaged the German government, and we even told them, if you want people especially they were looking for nurses. He wanted nurses to come to Germany and work. Come, let's look at 1 or 2 or 3 schools, get people into these schools, even doing their training for the 4 years for Bachelor of Nursing. They also do a language course and then go to also Germany for attachment, so that before they even finish, before those people are sent to Germany, they understand at least few German language, and they also know the system that works in Germany.
Okay.
And then they can they very quickly assimilate into their system.
All right.
So these are plans that in place. As I said, on Sunday, our friend Bella will give the broad headlines of what we're going to do, and then we'll continue with the conversation. We'll come to your station and then explain what you want to do, looking at the brain drain and taking advantage of the brain drain.
Right.
Also putting in plans to also mitigate the brain drain, and then how we can use the professionals also to entice people into the country, and also a direct foreign exchange into the country, including medical.
Right, understood. Dr. Nsiasare, stay with us. I want to bring in Dr. Richard Selome. He's the General Secretary of the Ghana Medical Association. Dr. Selome, thank you for your time and your patience. You've heard what plans the government has, and in fact, the party in power has going forward to stop brain drain. Will they work?
Well, good morning, Kojo, and good morning to your listeners. I heard parts of what Dr. Nsiasare was talking about because your line dropped a few times. As my president, president of the Ghana Medical Association, Dr. Medfang Sribo, said not too long ago, the biggest reason for which people are leaving, all professionals in general, and then doctors are leaving, is mainly economical. In the sense that their purchasing power in the market has reduced over a long time. And so, besides the example where, despite the best efforts of governments over the years, including this government that has made some good efforts to try to improve conditions of service, you actually, in terms of buying power, in dollar terms, for example, having worked for long, and improvements in your salary in nominal terms, have actually worse off in terms of what you can afford to buy with that money. I remember during house job time, when we had just left house job, Mercedes C-Class used to be called pure water, because generally when your back pay comes, with a little bit in addition, or even with that, you should be able to purchase a C-Class. Some people were able to purchase CRVs and co and that. Now, it is difficult because your salary converted to dollar terms, you are even worse off then, because that is the reality. And so the general economic situation is a big disincentive, because no matter how much you earn, the general average doctor cannot walk to a showroom to even buy a car, let alone go and purchase a house off. And so many people are asking themselves those questions, that after serving this country, after working all this while, what do I gain? How do I go home? If my salary cannot take me home, how do I go home? And that is the main incentive. Of course, admittedly, it is difficult for us to compete with the countries where people are migrating to. However, if we were able to put certain key measures in place, especially things that take care of the recurrent costs that workers face, like healthcare. Many healthcare workers would have to actually pay for their own healthcare in sometimes the hospitals they even operate. Sometimes the Ghana Medical Association has had to jump in. Of course, sometimes we even call on government when the costs are high. And so those are important discussions we must have, and like we are having rightly so now. So some of the measures Dr. Nsiasare has mentioned are things that have also been on the table for long. For example, the rural incentive package, beyond allowances, included many other things that we felt will motivate people, especially those staying and going to the rural areas. Because if you get these people to stay long enough, some may get married and may not want to go out again. Some may establish businesses and may not want to leave again. some may at least serve for a period before they think about leaving. However, this implementation of this, which has gone ahead, a team has worked on it, costed it and all that, has been stuck at cabinet for quite a long time. Of course, we have pushed that some aspects of it, the non-financial aspects of it, like promotions out of 10, sponsorship for postgraduates and other trainings, various other non-financial aspects of it, we've pushed that those ones should be done. There are some efforts and attempts to implement same. However, we realize that it's also not across board. The issue about residency is an issue that is very important, and of course some efforts have been made in this regard. School fees is no more. And again, where people are supposed to be released early enough to leave for school, specialized, and they then often stay. And so these are some of the things that we have spoken about, and I think Dr. Nsiansari have also spoken about, but we think the implementation of same has delayed. But the major underlying thing here is the fact that the general economic situation is such that the salaries cannot take you home.
Let me bring in Kwame Sapon-Asiedu, who is a DND Fellow on Public Health for CDD Ghana. Kwame, it's great to have you on the show again. Good morning. If it is predominantly an economic problem, then the solution is predominantly economic. And according to economics, the more scarce the resource, the higher the value. Really, should it not be as simple as that? Should the government of Ghana, the economy of Ghana, not already be paying doctors, especially specialists, a lot more for their unique skills?
Kojo, good morning, and good morning to Richard and Dr. Nsiansari. You have a point there, but paying more is relative. If you listened to what Dr. Salome said, and if you've listened to Dr. Frank Serbo, paying more should reflect purchasing power. So, for example, it would be wrong to say currently health professionals are not being paid more in CD terms compared with, say, 5 years ago. But it would also be wrong to say their purchasing power is the same as it was 5 years ago, because when they convert their salaries into dollars, they are worse off. So that is how I want to situate the question and say, Kojo, when you say pay more in what sense? Pay more to ensure that their purchasing power is improving, or pay more in the sense that the quantum of CDs they are receiving are improving? That's one thing.
It's a fair point. Let me clarify so we can answer the question better. So I'm talking about in relation to the scarcity of their service or the scarcity of their skill. Okay, so today in Ghana, should a specialist medical doctor not be paid more than, say, a politician? Bearing in mind it's much easier to find a politician than it is to find a medical specialist.
You see, Kojo, that was where I was actually going to, because it's an open secret that I work in the UK predominantly, even though I work in Ghana as well. But you would find that even some consultants in UK hospitals, and Dr. Nsiansari knows this, earn more than the Prime Minister, because as you know, all three of you on the moderators today, Winston and Raymond, have lived in the UK, and you know that these salaries are published openly, so you can find the consultants range, you can find it. You know what the Prime Minister is.
Yeah. And
there are some consultants who earn more than the Prime Minister, and you know that. And that is why I'm saying pay more in what sense? Is it pay more in such that their salaries are pegged based on their skills, as is done in some countries, so that yes, if he might be a consultant and is earning more than the Prime Minister, but nobody cares? Or pay more and ensure that their purchasing power, say, if when they graduated as a house officer, their salary was equivalent to £1,500 or $1,500 a month. Having worked for 10 years, whatever they are earning is equivalent to, say, $2,500 a month. because that would also be paying more. Those are the serious conversations we need to have, because the economics of it all is also got to do with political will and decision making. Because if you say, in countries like the UK, where the Prime Minister knows, like when Boris Johnson was taking on well, he had to be taken to Baths. You'll not be taken anywhere down to the hospital in your constituency. And all of you know that because of, what do you call it, the locality demarcations and all that, unless there is a subsequent referral. So the Prime Minister knows that to maintain that consultant in this country, so that when I'm unwell and I'm taking to him, I get the best health care. This is the, what do you call it, the going rate. Unfortunately, we've not designed our health system that way. Whether we like it or not, our politicians would sit on the next flight if they could and they were stabilized to go and see these consultants who are earning more than their Prime Minister.
Yeah.
So you see the cognitive dissonance in the question I ask, as in, what do you mean by paying more? Is it just to ensure that you maintain their purchasing power, or you are paying for the true value of their skills? Because they are two different conversations. And that is why I'm making this analogy, because if you go to the US, you go to Germany, to most countries, you find consultants and other things who earn more than the leaders of the country. It is known. And you would have thought that in a country like Ghana, where even the president said in 2017 that if you wanted to make money, you don't come in as a politician, you work out in the private or public sector, because that's where the money is. We would be comfortable with some of these propositions. But the truth of the matter is, we are not comfortable with some of these propositions. So now let me go back to a lot of the things that Dr. Nsiasare has said. On paper, Dr. Nsiasare is saying nothing different from what is contained in the Kampala Declaration of 2008. And I've shared it with Winston and all of you. So you have copies of the declaration that was made as to how to retain health professionals in lower middle income countries. The review of that Kampala Declaration was done in Accra in 2009. The sad thing is, 2024, how many years later, we are saying we are going to do the same things that was in a document that we appended our signature to in 2008. So, for someone like me who reads these documents as part of my way of working, because what am I? A fellow in research in health for CDD Ghana. So I read these documents. When I hear senior colleagues like Dr. Nsiasare talk, I go back and I compare what they are saying to what we actually signed up to do as part of being members of the WHO in a meeting that was chaired by Ban Ki-moon, who was then the United Nations Secretary General, because at that time, this was a serious problem. I asked myself, if we've not done it since 2008, what makes me think that going into a manifesto in 2024 is going to improve the situation? You understand me? So I am not disputing in one bit that what Dr. Nsiasare is saying is the right way to go, because it has been the right way since before 2008, to the point that it became a declaration of the United Nations and World Health Organization, which is still standing. The question I ask myself is, why have we had a government in power since 2017 and we're in 2024, 7 years, and they came to power 9 years after the signing of the Kampala Declaration. And not a lot of it has been implemented, to the point that at the time that the Kampala Declaration was signed, it was junior doctors that were leaving. Now specialists are leaving, which means the situation has aggravated. So yes, I'm happy with what Dr. Nsiasare is saying. And ordinarily, I'd say, bingo, let's go. But I need the politicians, be it NDC, be it NPP, because you'd realize that's why I go back to 2008, because after that, the NDC was in power till 2016. The NPP are subsequently taking over. Not a lot has happened in that document.
Yeah.
When I was invited to come onto this program, I went back to listen to the Public Accounts Committee sitting of the 30th of July. And I heard of a doctor who took study leave to train and subsequently was supposed to return to the Rich Hospital. But when I was returning to the Rich Hospital, they then got an opportunity to train as a consultant geriatric medicine person in the UK, so left. And this is the irony. We have no consultant in that field in Ghana. The people from the Rich Hospital were telling the members of parliament that we didn't have a specialist, and this person had gotten the opportunity to go and train. What did we hear? No, refer the matter to Yoko. That is the political will Kojo I talk about. The people sitting there didn't think, wait a minute, how have we since 1957 not had a specialist in geriatrics in the country? Now that we are getting the first one trained, we are not looking at special circumstances so that this would even be a limelight for other health professionals, doctors realize if I get a strict specialization like that and I have to leave because I cannot train in Ghana, I wouldn't be punished for availing myself to that opportunity. So you see, I bring all these things in, and then I go back to the Kampala Declaration and say that these things are all in the Kampala Declaration to ensure some of the things Dr. Nsiasare was saying to happen, where you talk about brain circulation, so that these people go and train, and even if they don't come back into the country, they are eager to come back and replow their intellect into the country so that we can start training our specialists in these areas where we do not have the expertise. But now we want to punish people for taking that opportunity. And that's why I'm asking the question of my senior colleague, Dr. Nsiasare, that why should I believe that it going into a manifesto is going to make a difference when it's a WHO declaration and it's made no difference? So, Kojo, this is how I come to this conversation.
Right.
Because the solutions are known. Like I said, I've sent it to you. It's on the Kampala Declaration. Clearly, Dr. Nsiasare has read it as a leader in health. He's eloquently espoused them. And I don't doubt his ability to implement them. The question is, why hasn't it been done?
Right. Well, that's certainly a question we would like to hear Dr. Nsiasare address, including this issue of what happened at the Public Accounts Committee. Doc, just before we hear from you, Dr. Richard Salome has to catch a flight, so let me just get a quick confirmation from him. Are you aware of this situation that came up at PAC, and how common and...
Hello, Kojo.
Yes.
Can you please take that again? I'm not sure what you're talking. Your line dropped for a while, so I'm not sure what you're talking about at PAC.
So Kwame Sapon-Asiedu raises an issue of a case that came up at Public Accounts Committee. Ridge Hospital had a member of staff that had completed training, was supposed to serve a bond, but had an opportunity to go and study geriatric medicine, which is a specialism that we don't have in Ghana at all. So she took the opportunity to go and study, and as a result, she was told she had to pay for the bonded period that she didn't serve. And the payment negotiations haven't been completed, but Public Accounts Committee has recommended that the lady be referred to Iyoku. And I mean, so the concept here is that, you know, she's actually getting penalized for pursuing a specialty that we don't even have here in the country. And I'm asking, is this common? Is it widespread? And how does that affect the desire of doctors to pursue specialties?
Well, to some extent, I've heard on this issue. However, some of the latter bits, I'm not fully appraised on them, and I would not want to speak to them. But what I would want to say is that when we approach issues from that penalistic point of view, you may end up driving people away. And then also where within the system, there are people who also abuse the processes, and then they are not as penalized as people like that. And then it is seen as though once you leave the country, then you have to be punished for getting out. That also is wrong. What I think is important is to see how, one, compliance with the processes when you also want to leave the country, and then also ensuring that we encourage people and entice them to actually come back and use the expertise that they learn to visit the country. One of the things that I was also going to touch on is the fact that we don't necessarily have to bundle people to come back to the country and stay full time. People may come in to even render service for brief periods. For example, when they are on leave, we should encourage them to want to come back and serve. Some will pass on expertise, like the emergency medicine program, which was the first in the sub-region, started in Konfanochi Teaching Hospital. One of the consultants at the time was not based in Ghana and was coming and going. He was a Ghanaian, but then, a U.S. citizen, but a Ghanaian of roots. And he was coming in, and one of those who helps establish that. Subsequently, fellows have been trained, and they are training people locally, and even for the sub-region, and one of the best emergency medicine training programs across the world. And so, the way we attempt those issues, being punitive and being high-handed, especially when health workers have to have such issues, is also not helpful. Let me just quickly add on that beyond economic issues is also the issue of employee well-being. Many of us have had to serve in areas under serious conditions where sometimes what you need to work is not available, and that affects satisfaction with what you even do. So there are people who have the skill, they have acquired the skill, orthopedic surgeons or obstetricians, gynecologists, and they do not have either the complementary specialists in other fields, for example, the nurses, the other devices, equipment, logistics to go with them. And so sometimes you have a patient right in front of you, you have the skill, but unfortunately you can't do much about it. Sometimes it's about ambulance referring this person and this whole issue about financing the ambulance itself. And so you lose patients in front of you that you can't handle. And people then get depressed with some of these. So employee fulfillment on the job itself is also one. Also, tightly linked to this, which may not be specific to health, is the issue of amenities. Very bad roads. Sometimes posting you to certain places essentially is as though you are being sentenced to a certain other world apart from where you work. People have had to go across streams to hard-to-reach areas. Sometimes the roads are bad. You don't have good schools to make sure your kids also go to school. So that the question arises, how do you serve when you yourself, you cannot live? And so you must live to let live. So we must look at this in a comprehensive manner. If you take Akosombo, for example, when the dam was being built, a township was constructed with an international school, with a swimming pool, with a clubhouse, with markets, supermarkets, etc., for the workers that work there. So people did not mind living wherever they had to go. Same with the mining towns. To go and live in these places because amenities are proper. It's an international school. Their kids, things are subsidized for them, and they are able to work hard knowing that some of these issues have been taken care of. Here lies the case. You get to work in a lot of places. The schools are not good, so you are thinking about where to take your kids. Where to take your kids to, the costs are so high, the economic situation doesn't permit you, unless probably you have to be running around doing locums and other things. So it's an issue that needs to be holistically looked at and bringing on board all actors. For example, not government should look at bringing on table private developers, the banks, other institutions to come on board. What does a health worker need for starters? Out of school, a house, a car to move about. Why can't we offer it such that it's a combo, a house and a car? If you work in Ghana for the next 5 or 7 years, we can discuss the period, so that by the time you work for that period, this car and house are yours. People will be forced, after working 3-4 years, to say, hey, if I leave now, I lose this car and a house. Let me serve the 5 years, get the house, even if I wanted to leave. You have had somebody who has served 5 years in that community, and another person will come and also serve another 5 years. And hopefully you have a stream of people being there, rather than leaving people to have to fend, and the economic situation, as we said, does not even augur well for them. So these are very, very key things, and especially the healthcare matters and mental well-being of workers, where we have to fork out money ourselves, and even associations sometimes stepping in, and sometimes government itself stepping in to pay healthcare worker their healthcare issues. Especially when a lot of these people, some of them, have acquired some of these by long work that they do, exposures to depressing situations, exposures to various infections. You remember we lost very key top specialists, including the rector of the Ghana College of Physicians and Surgeons, because of COVID, and he's gone, just like that. Yeah. So these are issues that I think that we have to mainstream, and we shouldn't be talking about we will do. We must begin to demand. And I say this in conclusion, that the people should not behave that we are innocent bystanders. Governments, in generic terms, governments, NDC, MPP, whichever government comes into power, administrates the country on our behalf. If we allow specialists to leave, which is becoming the trend, hematologists are leaving. So who is going to take care of your sickle cell patients? Specialists are leaving, where maternal cases in some districts, adjoining districts, they are preparing to leave. If they leave, all these people now have to spend more money to travel to, say, bigger centers, look for somewhere to stay, where they will buy food and etc. It will affect you, it will affect me. And so we must take active interest in these things and ensure that the governments who administer power on our behalf ensure that professionals are comfortable and want to stay, so that when we are sick, we'll get the best of care here, rather than some situations where people now have to take flights and go to India and go to other countries for some of the things that we can do here. We have the expertise and we have the people to do them here.
So, look, Kwame, you've pointed out that what we've heard so far by way of solutions from proposed solutions from government, it's all old hat. It's old stuff. Ban Ki-moon, superintended over some of these decisions. So it's old, and we still have the numbers rising of those leaving our borders. So what would work?
Well, thanks. What would work is the political will to implement what we know. I've always been one person who doesn't believe in reinventing the wheel. And that was why I was saying that a lot of the things Dr. Nsiasare is saying are brilliant, but we've known them since before 2008. So what would work is the political will. A lot of the time, and I was glad with something that Dr. Nsiasare said before we went on the break, and that is that we should all be involved in the health conversation. I've been saying this for as long as any of you can remember, where I was like, one of the reasons why I get into the health conversation, irrespective of all the knocks that you take sometimes when you get into it, is that health is too important to be left to just the politicians or the health professionals to have a conversation on. And I am glad that Dr. Nsiasare is saying the same thing, because you know what? Today you are a journalist. Tomorrow you are a doctor. Next minute you are a patient. And the tables can turn so quickly between you being the most senior consultant to you being the patient on the bed. And that is how important health is. So when I hear the people who we vest power into, like the likes of Dr. Nsiasare, because he's the presidential advisor, beginning to say and advocate that, look, don't leave these conversations to us alone. Whether it's NDC or MPP, we need to have these conversations, because the resultant actions, if we don't have these conversations and we don't force the political will for change, is that we would all get into trouble. So for me, the key thing, Kojo, is what you guys are doing now. Begin to ask the questions. If you've known the solutions since 2008, the follow-up meeting was had in Ghana in 2009, and the likes of Dr. Nsiasare, you are telling us now that we are going to do exactly the same things that we've known since 2008. Why haven't you done it till now? And what is going to make us believe that you are going to do it? But more importantly, what should we judge you by? What are the timelines? What are the milestones? What are the key performance indicators? Because I don't believe that just taking the Kampala Declaration and putting it into, be it NDC or NPP manifesto, is what's going to make the change. It's not going to make the change. So the question must be the strong conversation and holding people's feet to the fire to ensure that they prioritize our health professionals and have that key conversation around the economics. What sort of economics are we talking about? Are we talking about the economics where we pay for their true value? As I was saying earlier, where if a consultant's value is more than the president or the prime minister of a country, the president or the prime minister should not be bothered one bit if they earn more than them and are drawing their salaries from the same public payers that the president or prime minister draws their salaries from because it's happening across the world? Or are we going to have the economic conversation where we say we are going to retain their purchasing power based on the value and premium that our country puts on them? And if that's the conversation we are going to have, is that purchasing power prioritization enough to stand the brain drain? Because at the end of the day, whatever decision we take, if it doesn't stand the brain drain, then we are better off not taking it. So these are the things that I believe can be done to try and fix this.
Right. Do we have Dr. Nsiasare yet? Okay, we're working on that. But Kwame, I want to thank you for your time with us. As always, very elucidating conversation. We appreciate it. Okay. Listen, guys, I mean, having listened to this, a couple of things occur to me. First of all, it seems that we've decided as a nation to use the stick more than the carrot when it comes to, retaining our medical professionals. So we will bond them into working a couple of years before they can go off and do other things. We'll bond them. I mean, we'll indenture them into some servitude for some 2 years before we let them go work elsewhere. Dr. Richard Selome suggests, why not incentivize them? Put a pot of gold at the end of the rainbow. Tell them, if you work for 7 years, you get a house and a car. So much as they would rather, go off and do other things, they will serve the 7 years to get the reward at the end of it and go. And then others will come and do the same. So that we'll continuously be getting a steady stream of people committed to at least some 7 years, during which, who knows, they might get married, have kids, and even abandon any plans to go elsewhere. Would that not work better?
How about a combination of all factors that work at specific periods? Because we like alternating things. Either or might not work for any system. So policy rethinking would require that, for example, and I know this has happened before. I had a classmate who, when he was at the University of Ghana Medical School, it was his district that paid for his schooling. And he spent a long time in the district. In fact, he only had to leave for school and stayed teaching and has plans of even coming back. What he then did was paid for more than 20 more students from that same district fully for their education. To him, without having to get that payment coming from the district, there's no way he would have been able to fully fund his university education. So to him, it was absolutely necessary. District took charge of that. District, not central government. It was a decision of a DC that we have all the things we can do, but we need to invest this amount of money into 4 students. One in engineering, Henry was the one who was actually doing the medical sciences. That is also possible. District can decide that instead of always buying rice and sharing, we can actually prioritize some of these things. But ultimately, no matter what you do, I think this morning, right from the kinky conversation through to this particular conversation of who is living and going where, no matter how you fix the values of the people, there are some economic decisions that if you do not make, it forces people out more than other factors. Because, Kojo, I hear people say you can work actively in the best of professions and serve your nation for 35 years. And that people who have worked for less than 10 years in other very profitable ends will be the ones seeing the very best of consultants, and you can't even pay for that transportation. And your kids will see you as irresponsible, as only having a name that you've earned for yourself, but with nothing accompanying that. So those conversations, they are not limited to certain families. Everybody would want to be having a dignified retirement. And at the original end of the conversation was that Dr. Hadi Abdullah put out there 35 years of working in other countries or working in the Republic of Ghana. Some have come to believe that they'll have a better retirement with just 5 years working elsewhere. We should be able to narrow that gap if we cannot completely even the space. And we cannot be fancifully speaking, people are not so ideologically inclined in the republic that this is my state. No matter what, I'll work here. No matter whose horse is God, I'm working only for Christ. So you need to make sure that the systems work so people can choose to stay.
Right.
You see, when you listen to Dr. Salome, he talks about this whole problem also being a development problem. And if it's a development problem, that's why I consistently keep saying that, we're running a system which ordinarily should be solving our problems. But unfortunately, again, because of the political elite and their greed, they've centralized the very system that was supposed to have helped us. Why? The district assembly, in recruiting the best of professionals, must actually create the environment that can sustain these professionals.
Yeah.
So the district assembly must actually put in place the best of schools. Okay, get the best of teachers to come and teach in your school. Go out there, instead of the district assemblies consistently hiring people every year who get onto the payroll of the assembly, and when there's a change in government, these same people leave the payroll of the assembly and another batch are brought in who are funded by the internally generated funds. Instead of the district assembly hiring people to go collect money on its behalf and giving them 30% instead of, say, 10%, the district assembly can use all these funds to do what? To actually develop the district. How? So we need to attract the best
The
of
DC
doctors.
has a building,
Yes.
nice building. Next to the DC's building is the doctor's quarters.
Yeah.
He'll feel that he's in a privileged place.
So look, there were certain areas, rural areas, that attracted the best of professionals. And I'll explain why. At the time in the old Mpawasa East District, the district capital was Dabuase. They had Subri, SIPL, Industrial Plantation Limited. SIPL, because, of the activities there, they built a school, had the best of teachers there. And so the workers took their children there.
Precisely.
And from, Dabuase, they went to the best of schools in this country. They went to all the 8 schools in this country. The point I'm making is that the assemblies, if we're going to deal with this, once the assemblies begin to show and then advertise, Raymond has talked about, funding these things. The very first time I heard of this was in 2000 when my late uncle was talking about how the district assembly at the time had decided to send people to the training colleges or the colleges of education. So they did come back and teach in the schools, the schools in the community.
Yeah.
The point I'm making is that today, look, it is not central government that would have to say, work for 7 years and I'll buy you a car. In fact, the district can actually say, the doctor has this vehicle, come and work. After 5 years, we'll give it to you. The district can say, come with your children. They'll be on scholarship while they go to school. Because we have a school here built by the district. And all these STEM schools that they
are now doing all over the country.
The district can do, look, the district can build them. Why do we make it so difficult that at every point
Because
in
the
time we have to
people
go and look for
send
central
to the
government?
district, we don't send them to go there and work. We send them there as a reward. They go there on retirement.